Welcome back to part 2 of our 3-part explainer series on disposition decisions in the emergency department. If you caught part 1, you know we tackled rapid risk stratification. Today, we're shifting gears to what comes right after, the discharge. So today we're really breaking down the anatomy of a defensible ED disposition for your dizzy patients. This is a super pragmatic protocol, explicitly designed for you, emergency physicians, vestibular physicians, and GPs handing these patients back out into the community. Look, safe discharge isn't just checking to see if red flags are missing. It's about having a rock-solid, defensible formulation, a thoroughly documented plan, and a patient who is actually genuinely ready to head home.
Which brings us to our core principle for the day. A safe discharge is a structural event, not a gut feeling. We absolutely have to anchor on this, because getting dizziness disposition wrong, it carries massive medical legal weight. In the high-stakes chaos of the ED, your intuition just isn't a defensible standard of care.
Here is our protocol-driven framework for today. We'll cover why structure beats a gut feeling, the specific criteria for a safe discharge, and component-by-component documentation. Then we'll dive into crafting that defensible reasoning paragraph, specific return precautions, and finish with our key takeaways.
Section 1. Structural, not a gut feeling.
All right, here is the absolutely crucial point. Missed posterior circulation stroke is literally the most common successful medical legal claim against ED clinicians in acute vertigo cases. Let that sink in. The highest risk consistently comes from one specific scenario. Older patients with vascular risk factors who get a quick, incomplete exam, get slapped with a benign label like vestibular neuritis, get discharged, and then bounce back with an evolving cerebellar infarct. It's a medical legal nightmare.
So, this clinical pearl is basically your danger zone reminder. Think of it like a strict mathematical formula. Any combination of acute vertigo, plus vascular risk factors, plus focal findings equals high risk, period. Image and admit. In these scenarios, doing a structured exam, including HINTS plus and formal gait testing, along with having a very low threshold for an MRI, is the absolute standard of care. It's not optional. When you're in doubt with this demographic, you admit, no questions asked.
Section 2. Criteria for safe discharge.
So what does that actually look like? Well, there are 5 convergent criteria that must all be met before you even think about sending that patient back into the community. First, you need a clear, benign diagnosis that is actually confirmed on examination. I mean, seeing BPV confirmed by a Dix-Hallpike test, not just guessing based on their history. Second, you need reassuring exam findings across the board, normal gait, normal cranial nerves. Third, you want to see actual symptom improvement while they're sitting there in the ED. Fourth, absent or very low vascular risk factors. And finally, reliable follow-up and a safe home environment. Hitting all 5 gives your decision a strictly defensible foundation.
Now, a huge safety signal within that foundation is functional readiness. To put it simply, the patient actually feels better, they can walk completely unaided, and they can keep down fluids. If your patient has ataxia, meaning they literally cannot stand up without help, they are not ready to go home. Full stop. That inability to stand is a massive predictor of central pathology and a highly practical barrier to a safe discharge.
Section 3. Component-by-component documentation. Think about this contrast because it's a real game changer. Writing down HINTS reassuring is completely medico-legally indefensible. You have to document your HINTS assessment component by component. For instance, write head impulse test negative, nystagmus direction fixed left beating, skew absent. Why go to the trouble? Because in a court of law, an undocumented examination finding is treated as an examination you simply didn't do.
So your chart needs to hit this minimum data set to be considered complete. You need the history, onset, triggers, vascular risks. Your exam notes have to explicitly call out normal findings. And please, don't forget gait testing. Include that right alongside your targeted cardiac and neuro exams. Finally, you've got to document your testing, your differential diagnosis, and your reasoning.
Section 4. The defensible reasoning paragraph.
This right here is your ultimate clinical shield. It is the single most important documentation element for your medical legal defensibility. State exactly what differential diagnoses you considered, what you excluded, and exactly why you think a discharge is safe. Don't leave it vague. Don't just imply you thought about a stroke. Explicitly write down that you considered a posterior circulation stroke, you ruled it out based on specific reassuring examination findings, and therefore you determined the patient is safe for discharge. Make your thought process bulletproof.
Section 5.
Advice and return precautions.
Once you've made the call to discharge, you have to provide clear, written, and verbal return precautions covering these exact red flags. Tell them, point blank, to return immediately for a severe or worsening headache, any new weakness, double vision, slurred speech, facial droop, sudden hearing loss, or new unsteadiness. We're not talking about generic, come back if you feel worse warnings here. These are the specific, textbook indicators of evolving posterior fossa pathology. They need to be hypervigilant about these exact symptoms.
Also, this advice might be a bit of a paradigm shift depending on when you trained. But bed rest is absolutely not recommended for vestibular neuritis or BPPV. It actually delays central compensation. So advise a gradual return to normal activity instead. You should also hand them a vestibular physiotherapy referral, because that improves outcomes significantly, and clearly counsel them on driving restrictions during active attacks based on your local laws.
Section 6. Takeaways and next steps.
The clinical scenarios we're outlining here do a fantastic job of illustrating our entire framework in action. Just look at the top. Clear, benign presentations. Say a younger patient with BPV. You can safely discharge them with an Epley maneuver and some physical therapy. But glance down at the middle. An older patient presenting with acute vertigo, hypertension, and any concerning findings. That combo, it mandates admission and MRI imaging immediately. Tailoring your disposition precisely to the clinical scenario, that is how you practice safely.
So keep these 3 main takeaways in your back pocket every single time you prepare a discharge formulation. Number 1, ensure all 5 convergent criteria are met before you even think about discharging. Number 2, never just write hints reassuring. Document every single component. And number 3, remember that a short, highly explicit reasoning paragraph detailing exactly what you considered and excluded is going to vastly outperform a massive, thoughtless list of normal findings.
Thanks so much for watching this explainer. To dive into more topics around dizziness, vertigo, and imbalance, and to grab some fantastic clinician and patient resources, head over to AustralianDizzinessClinics.com. Don't forget to subscribe and leave us a rating. And definitely join us for part 3 of this series, Referrals and Medical Legal Considerations, where we're going to build out the outpatient network and fully close the loop on those risks lurking under every disposition decision.
I'm going to leave you with this final thought to kind of audit your own charting practices today. Take a hard look at your notes and ask yourself, are your discharge summaries simply listing normal findings, or are they actively defending your clinical reasoning? Think about it, and I'll see you in part 3.